This is Dr. Gary Heller, a member of the Cardiovascular PET Task Force. I'm here with Dr. Dennis Kalman to discuss one of the cases for the ASNC website. The title is FDG PET for Assessment of Myocardial Viability. Dr. Kalman is Director of Cardiovascular Imaging at Riverside Methodist Hospital in Columbus, Ohio. Dr. Kalman, thank you for joining us. Please give us a clinical history of the patient that we will be discussing, as well as why cardiac PET studies were recommended for this patient.
Great. Thank you very much, Gary. It's my pleasure. I'm going to present a case of a 54-year-old man who presented with substernal pressure and mild troponin elevation. Blood pressure was elevated on presentation, severely elevated at 176 over 116 millimeters of mercury. He had a previous history of prior drug-eluting stenting to the LAD 2 years ago, but at that time he left the hospital against medical advice and took no cardiac medications for 6 months following the stenting, including he took no dual antiplatelet therapy, which obviously puts him at risk for stent thrombosis. Cardiac catheterization was performed as the initial test to evaluate this patient, and as you can see here on this left coronary angiogram, there was total occlusion of the LAD proximally. The right coronary angiogram shows faint collateral filling of the distal LAD. The LAD territory was akinetic on the left ventriculogram, which is not shown, with an ejection fraction of 25%. So at this point in time, there was quite a bit of indecision as to whether or not this patient would benefit from myocardial revascularization based on his previous history and based on the findings of the invasive coronary angiogram. For these reasons, the decision was made to refer him for a viability assessment with cardiac PET.
Thank you, Dr. Kalman. Can you describe for us the steps that you take in using a viability assessment with cardiac PET?
Yeah, thanks, Gary. We like to, in our laboratory, to always, if possible, perform an ischemic evaluation with vasodilator stress, for example, before going on to the complete FDG, and we'll talk about that more in this case, but we find that an initial ischemic evaluation in many cases answers the question very clearly of myocardial viability, and FDG imaging is not required. So in this case, we started out with a standard rest and peak stress rubidium PET myocardial perfusion imaging study. As you can see on this slide, this is the quality control display, and you can see by the green dots on the left that all of our quality parameters were within normal limits, suggesting that this would be a good quality study in terms of registration, patient motion, and other quality indicators. These are the rubidium PET myocardial perfusion images obtained at peak stress and at rest. And as you can see on these images, there's a severe perfusion defect in the entire LAD territory on peak stress images. When compared to resting images, there's also a severe perfusion defect. Visually, there appears to be some mild partial defect reversibility, which obviously implies the presence of some residual myocardial ischemia and implies the presence of at least some residual myocardial viability in the LAD territory, although based on the fact that the defect reversibility was very minimal, there was still quite a bit of indecision as to how much myocardial viability was present and whether or not the patient would benefit from myocardial revascularization. The semi-quantitative perfusion assessment on polar maps similarly showed a very large and severe perfusion defect in the LAD territory with a very high summed stress score of 35. Resting images also demonstrated a severe and extensive defect, though slightly less extensive and slightly less severe, with a summed rest score of 21. The sum difference score of 14 obviously implies the presence of some degree of myocardial ischemia, and again implies the presence of at least partial viability in the LAD territory. But again, whether or not there's enough residual viability to justify attempts at revascularization was the question. We can also take advantage of quantitative perfusion polar map displays. And again, here we see that the stress defect was quite severe and extensive. And compared to resting images, the column on the right shows the defect reversibility, and there was some residual defect reversibility, particularly in the border zone peri-infarction LAD territory, suggesting at least a rim of some residual viable tissue. But again, based on this and the fact that the defect was quite severe in the resting images, there was question as to how much myocardial viability was present. The quantitative polar maps can be displayed in a variety of ways, and remember that rubidium is taken up by the myocardium in a similar manner to thallium through the sodium-potassium ATPase, and therefore quantification of resting rubidium uptake, just like thallium, can be used as an assessment of myocardial viability. If you use different thresholds, you'll come up with different answers. For example, as you see on the left of the screen, if we were to choose a 30% threshold comparing regional tracer activity in the LAD territory to the normal reference regions, you'll see that we would come up with an impression that most of the myocardium is viable and only 2% of the left ventricle would fall below this threshold, and only 6% of the LAD territory. If you look at the other extreme on the right side of the screen, you would see that if we set a threshold of 60% for uptake, then 47% of the left ventricle would be considered to be non-viable, or 79% of the LAD territory. Obviously, this changes as you set the threshold. The conventional threshold would be 50%, and as you can see in this column, we would estimate that 24% of the left ventricle is non-viable, and 48% of the LAD territory would be considered non-viable based on this threshold of resting rubidium uptake. So again, even after this type of assessment, there was still some uncertainty as to whether the patient would benefit from revascularization. The gated PET images are shown on this slide, and you can see that the resting ejection fraction was severely reduced at 26%, and at peak stress, the ejection fraction rose just a bit to 31%. This increase in ejection fraction at peak stress likely reflects the fact that the right coronary and left circumflex territories are well perfused and able to increase contractility during stress. Again, the fact that there's severe regional dysfunction in the LAD territory, both at rest and at peak stress, does not completely answer the question of myocardial viability, as this severe dysfunction could represent severe resting ischemia or permanently infarcted myocardial tissue. Absolute myocardial blood flow assessment was also performed as per our routine in our laboratory. The resting blood flow in the LAD territory was severely reduced at 0.52 milliliters per minute per gram, and during peak stress, the myocardial blood flow fell slightly further to 0.46. Therefore, this resulted in a myocardial blood flow reserve of 0.9. Blood flow reserves below 1 imply that there's actually coronary artery steal phenomenon taking place, which is something that we do see in patients with totally occluded arteries dependent on collaterals. The fact that the global myocardial blood flow reserve in this case was also fairly severely reduced likely reflects the fact that the LAD territory, being quite large and with such severely reduced myocardial blood flow reserve, impacts the global flow reserve as well. Again, based on these findings, it remains unclear whether the LAD territory is viable or not, as this could just represent very severe resting ischemia with residual viability.
So Dennis, in your laboratory, it sounds like the first, if somebody calls you up and wants to do an FDG viability study, you would move them in the direction of assessing for ischemia first, followed by an FDG study after that. Is that correct?
Absolutely, and I think that's very important. And if you look at the ASNC guidelines for PET imaging with FDG, they also support this kind of approach. This slide outlines our approach to patients referred for viability testing with PET. We first start, again, with rest and stress perfusion imaging, especially if the patient has not already had an ischemic assessment with SPECT, for example, to look for ischemia. If there is moderate to severe inducible ischemia present in the myocardial region of interest, particularly if resting myocardial blood flow is relatively preserved, then this finding implies the presence of significant myocardial viability and ischemia and strongly predicts benefit from myocardial revascularization. So these patients will simply stop here, not perform the FDG portion of the study, and tell the referring physician that this patient has significant myocardial viability, has significant ischemia, and is very likely to benefit from revascularization. On the other hand, patients with no significant ischemia, or like this patient that we're presenting now, has minimal partial defect reversibility and partial ischemia in the infarct zone, then we find FDG PET imaging to be very useful and use the results of the PET imaging with FDG to determine whether the patient has viability and would benefit from revascularization or predominantly non-viable myocardium and should be referred for consideration of device therapy or even transplant.
That's terrific. Let me ask you a couple of questions. First off, if you're in a situation in which you're not doing either ammonia or rubidium PET, can the ischemia workup be done with SPECT rather than with either of these PET tracers?
Yeah, absolutely, and that's a very good point. We prefer to do the ischemic evaluation with PET if possible, just because then the FDG images would be more closely matched with the perfusion assessment, because both images would be performed with PET and would be attenuation corrected in a similar manner. So we prefer PET if possible, but you can certainly use the SPECT, technetium-labeled SPECT tracers and perform ischemia assessment in that way, and then decide on using FDG only if there is absence of severe inducible ischemia by SPECT.
Well, that's very important, because obviously some laboratories do not have access to either rubidium or ammonium, but still could do an FDG study, so they would start with the SPECT rather than PET. So the next question is, in terms of preparation for an FDG metabolic study, can you just briefly describe how that's done?
Well, I think the details would be best found, as it is a little bit complicated, and best probably found in the ASNC guidelines for FDG, but I will just comment that when performing viability testing, we do want the myocardium to be taking up glucose. This is very different than when we do FDG imaging, for example, for imaging cardiac sarcoidosis or for imaging for device infections or prosthetic valve infections. In those cases, we prefer the myocardium to be using fatty acids for metabolism, because we don't want uptake in the normal myocardial regions, which would confuse the assessment. Here we are trying to encourage the heart to use glucose as its preferred substrate, so the preparation is very different. But that is very important.
Good, good.
This slide shows the sensitivity and specificity of different imaging modalities used for myocardial viability assessment, and you'll see that at the highest little box on the screen is for FDG PET, and this is the test that really has the highest sensitivity for detecting myocardial viability, and it's really the only imaging modality available that directly is able to detect hibernating myocardium, and that's why we find it very useful for its high sensitivity. On the other hand, dobutamine echocardiography, which you'll see sort of at the bottom right, is the highest in terms of specificity, but has quite a bit lower sensitivity. So when choosing tests for viability assessment, it's important to keep in mind the strengths and limitations of the different imaging modalities that are available.
So if somebody came to you and they said, I want to do a thallium viability study, what do you think what would you say is the difference in your own experience between doing a rest redistribution thallium versus a metabolic study with FDG?
Well, I think the advantage of the FDG, again, is that FDG is very avidly taken up by ischemic myocardium, so it's very sensitive for detecting hyperperfused, hibernating myocardium. Thallium, on the other hand, even if done with redistribution, really just looks at residual uptake, but it can still be affected by very severely reduced myocardial blood flow, even with delayed redistribution imaging. So again, I think of the thallium more, analogous to the resting rubidium uptake, and then the FDG adds that additional ability to detect hibernation.
So your thought process is that the metabolic study is really an excellent comparison with a perfusion study, regardless of which it is. Most
Right.
people would use rubidium. So there's some real advantages to doing FDG metabolic study.
Yeah, that's my impression for sure.
And what were the results in this particular patient?
So we went on to do FDG because there was still quite a bit of uncertainty as to how much myocardial viability existed. So we did perform FDG, and as you can see on this slide, directly comparing side by side the resting rubidium uptake to the FDG activity, that there's a very severe reduction in FDG uptake throughout the entire LAD territory, which would be very suggestive that this is mostly permanently scarred infarcted myocardium with very little significant residual myocardial viability. Here you can see on the polar map display, again, comparing resting perfusion with rubidium on the left and glucose metabolism in the right, that the defect of FDG uptake in the LAD territory is quite severe and extensive, again, implying that there is really very little residual myocardial viability present. And again, I can say that fairly confidently because of the fact that in patients who do have residual viability, we'll very clearly see glucose uptake in the ischemic hibernating myocardial region. In fact, sometimes that region will take up more FDG than other normally perfused regions just because ischemic myocardium tends to preferentially use glucose for its metabolism.
So this is what's called a match. Am I correct?
Yeah, so this would be a matched pattern where there's a matched reduction in perfusion and FDG uptake with metabolism. So this would imply permanently scarred, non-viable myocardium and would suggest that there would be very little benefit to myocardial revascularization in this patient's case.
So how did this study help you in the case of this particular patient?
Well, this type of a result would imply that the patient should be referred for other treatments, medical therapy for the ischemic cardiomyopathy, possibly defibrillator therapy if the ejection fraction remains below the threshold of 35% after medical therapy. And if he does poorly, he might be considered for transplantation or LVAD, those kinds of advanced treatments. But myocardial revascularization would be unlikely to benefit him. He's got a normal right coronary, a normal circumflex coronary, and the LAD territory, based on this very sensitive test for viability, is really found to be mostly non-viable.
Well, it's very helpful. So it sounds like in this case, before the FDG study, there were some questions as to whether the patient should have revascularization, but in this case, this was a match and therefore became a non-candidate for revascularization. So I'm assuming this was quite helpful in this particular patient's care.
That's right. And in fact, we've had several cases in our laboratory where the defect was very non-reversible, just a completely fixed defect with very severely reduced rubidium uptake both at peak stress and rest. And the FDG images showed very clear, very normal FDG uptake throughout the territory, suggesting viability. So because we do see, very clearly FDG uptake in those cases, we felt more comfortable that the absence of FDG uptake in that territory in this case really was a very reliable indicator of absence of viability.
Terrific. Let's go through the two questions. The first question is, FDG is always necessary for the cardiac PET assessment of myocardial viability, true or false?
I thought that the correct answer here would be false, and as I mentioned during the discussion of the case, beginning with an ischemic evaluation I think is very important because in many cases, patients referred to our laboratory for myocardial viability assessment, the rest and stress perfusion images demonstrate definite inducible ischemia and very normal resting uptake of the tracer, which by itself implies the presence of myocardial viability as well as ischemia. And the presence of ischemia, as we all know, is really the biggest predictor of benefit of myocardial revascularization. So in those cases, FDG is not required to make the decision regarding myocardial viability. The patient can be referred for revascularization confidently based on just the rest and stress perfusion imaging alone. But in patients like the one I just presented today, when there is still uncertainty after the rest and stress perfusion imaging, that's where I find FDG imaging to be very helpful for refining the decision making.
Terrific. That's a great response. Question 2, which of the following is the most sensitive test for detection of viable myocardium? A, cardiac MRI with gadolinium, B, cardiac PET with FDG, C, dobutamine echo, and D, resting technetium SPECT. So the question is most sensitive test.
Right. So as we discussed, when comparing the different imaging modalities available for viability assessment, cardiac PET with FDG is really the most sensitive and the only test that directly images hibernating myocardium directly. Cardiac MRI sort of looks at the extent of scarring and the extent of the left ventricular wall thickness involved with scarring, and therefore predicts absence of myocardial viability in this regard. But what cardiac MRI is not able to do is really determine whether the myocardial region is ischemic or hibernating. It's really more of a scar imaging type of a test, which is useful in many cases, but not quite as sensitive for detecting hibernation. Dobutamine echocardiography looks for contractile reserve, which when present is a very specific indicator of viability. In fact, with dobutamine echocardiography, the thing that is most helpful is when patients have a biphasic response, where the myocardial region starts with akinesis and therefore makes you wonder whether it's viable or permanently scarred. And then at low dose dobutamine, there's increased contractility in that myocardial region, which implies some degree of viable myocardium with contractile reserve. And then at higher doses of dobutamine, the same myocardial region becomes akinetic again, suggesting ischemia. So this type of a biphasic response, which is rarely seen but very helpful in predicting improvement with myocardial revascularization, but dobutamine echo in general is less sensitive. It's specific but less sensitive for detecting viability. Resting technetium SPECT or resting thallium SPECT obviously can be an alternative method for looking for residual resting myocardial blood flow, implying the presence of significant residual myocardial viability, but it's not quite as sensitive as FDG for detecting the very hypoperfused but viable hibernating myocardium.
Excellent. So finally, there are 2 teaching points. If you could briefly describe those, what
right. I think
you'd like this message to be.
Right. So I think to summarize this case, cardiac PET perfusion imaging, even without FDG, can be used to assess myocardial viability based on the presence and extent of myocardial ischemia and preserved resting myocardial perfusion. That alone implies viability and predicts improvement in outcome with revascularization. And secondly, assessment of myocardial metabolism using FDG PET is useful for detection of hibernating viable myocardium when the results of the standard perfusion assessment are inconclusive.
Terrific. Well, thank you very much for joining us today, Dr. Kalman.
It's been my pleasure. Thank you.